Good afternoon, and thanks to Extral for allowing me to share with you the preliminary results of our CliniCAT trial. Why did we think about making a trial using low-dose radiotherapy? There were several reasons. Our company is highly compromised with research overall when we can help improving the quality of life of many people, because you all know arthrosis is a very prevalent disease worldwide, especially in Western society. It affects about 10–15% of people over 60. For example, in Spain, Gonarthrosis affects more than 5% of general population, and Coxarthrosis affects almost 14%. The aging population is increasing, and it is very usual to have morbidities that doesn't allow to use common treatments like surgery, anti-inflammatory agents, analgesics. But all people and doctors usually are concerned of radiation-induced tumors and possible side effects caused by radiation despite the very low risk reported. When we read the DIGRO guidelines, they recommend using a total dose between 3 and 6 gray with a dose per fraction of 0.5 and 1 gray. We try to demonstrate that 3 gray has the same anti-inflammatory effect than 6 gray. So in the future, we can use the minimum recommended dose and minimize the already low risk of radiation-induced tumors. These are our objectives. The main one is to research the non-inferiority of 3 gray versus 6 grays in knee and hip arthrosis in terms of pain. We use the visual analog scale for this measure. And the secondary objectives were to clarify the effectiveness of the treatment in general and prolongation, to collect the side effects, to know about the quality of life improvement, and to clarify if our patient reduced the quantity of analgesics. This is the visual analog scale, and as you all know, it is very easy to use for all the patients, and it is validated for the scientific community. And here we have the West Ontario and McMaster University questionnaire for knee and hip in its Spanish version from the Spanish Society of Knee. This questionnaire has 3 sections. One for the intensity of pain, a second part to measure the stiffness of the joint, and the last part to measure the functional capability. What about the design of our trial? It's a non-inferiority trial, so we are weighting a non-statistical difference between the arms of the study. All our centers in Genesis Care Spain have participated. It is a prospective study and randomized in 2 groups, and only the patients did not know in which group they were being treated. This is our decision algorithm, where there are 2 important steps. Here, with the first randomization, at 3 or 6 gray, when the patients came to the baseline visit, and another one here in the 3 gray group, when they need to repeat the treatment 8 or 12 weeks after the first treatment. How did we select the patients? Our inclusion criteria were people over 50, at least 1 year of arthrosis evolution, to be treated with usual treatment previously, or to have comorbidities that made these treatments impossible or not recommended. Patients must be able to follow up, and they had to sign an informed consent. And the exclusion criteria were to receive high-dose radiotherapy previously in the location, connective tissue disorders, inherited hypersensitivity syndromes, and to participate in other clinical trials. And how was the development of the trial? Well, we had several difficulties. The study was approved by 2 research ethics committees. This is the consequence for having many regional health systems in Spain. Patient recruitment started in May 2019. At the beginning, the recruitment was very slow because there is no tradition of low-dose radiotherapy for arthrosis in Spain, and we did not receive patients from other doctors. It was very difficult to get patients. After that, we have another setback. COVID-19 pandemic appeared, and along the first wave, we have to stop the recruitment and wait until our centers were safe and COVID-free. As a result of the fear to COVID-19, we suffer other difficulties with the follow-up and the treatment of patients. They didn't want to come to health center, so we had to do the follow-up by phone. We have to collect all these data in the baseline visit, sorry. Data like birthday, gender, height, weight, body mass index, location of the arthrosis, previous treatment, the visual analog scale, and the WOMAC questionnaire. In the visit at the 12 week after the finishing of the treatment, again, we collect the BAS, the WOMAC questionnaire, data about the radiodermatitis, and if the patient suffered any side effect, and if it was necessary to repeat the treatment or not. And in the 6-month visits, again, we have to collect the VAS, the WOMAC questionnaire, data about the possible radiodermatitis, and if our patients took less medication or not, if they needed other treatments since last visit, and if they had any side effects or not. And finally, our preliminary results. This is the distribution of patients by centers. We have to highlight 3 centers where we treated the most of patients in Talavera de la Reina, Málaga, and Benalmádena. We treated more women than men, 70% versus 30% approximately, with a median age of 73 years. And we treated more knees than hips, with an 87% versus 13%. And the BAS median was 8 at the baseline visit, and the total WOMAC was 54 of the median. This is a picture, a photography of what happened on May 31st, 2021. We finished the recruitment, and in this moment we have recruited 229 patients. 181 patients finished the treatment in this date, and 110 had a 6-month visit of review, and only 8 patients in this date did not finish the treatment. About the toxicity and the side effects, we have to say that the treatment is very safe. Only has had 2 radiodermatitis, 1 in each group, 2 cases of transient increased pain in the 6th grade group, 1 case of venous thrombosis in right lower limb, again in the 6th grade group. And here you can see the BAS evolution at the baseline and 6 months later, with improvement in the pain in more than 70% of the patients. The red line is the 3 grade groups. The green line is 6th grade group, and this is the general group. And you can see the same, but in a table where you can see that the BAS evolution is very similar without without a statistically significant difference between the groups, with very similar median values. The same happens with the BAS evolution after 6 months in terms of mean plus minus standard error, where it is confirmed that not a statistically significant difference are found. Nevertheless, it should be noted that exists a trend in favor of 3 grade groups, which shows a greater decrease in pain, 49% versus 41%. And the same happened with the WOMAC questionnaire in terms of mean plus minus standard deviation. There are no statistically significant difference between the 2 treatment groups. Here you have the P. In terms of median values of the WOMAC questionnaire is the same. There are no statistically significant differences between the 2 treatment groups. And the same for the in terms of mean plus minus standard error, where the P is, you can see the P's, and there are no statistically significant differences found between the 2 treatment groups. In conclusion, we can say that 3 grade is not inferior than 6 grade. Both doses are effective in both locations. We got an improvement in a high percentage of patients. There are no side effects in our series, only very few side effects only in grade 1. And we got an improvement on the quality of life of the patient that was measured with WOMAC questionnaire. And the analgesic reduction analysis is in process. And we can recommend using lower doses. And of course, we have to recommend low dose radiotherapy in arthrosis. Thank you very much for your attention.
Thank you, Dr. Rivas. So the first question is, after seeing a response that's poor, do you repeat the treatment? Can you describe a little bit more about your protocol in that area?
We thought that a good score is when at least the BAS reduce about 2 points at least. But sometimes if you have a very low BAS, this is it depends on the initial BAS. For instance, you have in the pictures, in the slides, that the range of the BAS goes to 3 to until 9, if I remember well. So if you have a BAS of 3 points, the reduction in 1 point is very important. But if you have a BAS of 9 points, if the reduction is 1 point, the reduction is not very important. So it depends on the baseline of the BAS, and it's important to have the points in the total and the part of the pain in the WOMAC to think if it's necessary or not to repeat the treatment. This is our criteria for repeat the treatment or not.
Okay, thank you. Next question is regarding other treatments that are currently offered in Spain. Is systemic steroid anti-inflammatory or surgery offered as well in your practice in Spain in particular?
The question is about if we accept surgery, patients with surgery previously.
I think the question is regarding any other additional treatments that you might be providing, such as systemic steroid, anti-inflammatories, or surgery in conjunction with radiation therapy.
We try to use only the radiotherapy, and if necessary, if the pain is not decreasing, we try to prescribe analgesics, anti-inflammatory agents, or others. But if finally, when you get the finish of the treatment and there is no response in perhaps 6 months or more months, then it's possible to make, after the treatment of the radiation, you can to make surgery or other physical treatments. Because the radiotherapy, the low dose radiotherapy, is not a contraindication for others treatments. And never mind if you were if you had a surgery previously, or if you, after the radiotherapy, are going to need a surgery, for instance, for try to improve the condition.
Okay, thank you. And just a reminder to all the attendees, if you have any questions for Dr. Rivas, you can submit those questions using the GoToWebinar control panel. And I'm just going to go ahead and move on to the next one, Dr. Rivas. Where was the dose prescribed?
Yes, the dose prescribed here in the 3 grade groups, it was 3 grays as the total dose, and the single dose was 0.5. And in the second group, that is the 6 grade group, it was 6 grays in 1 gray per fraction. We elect we chose these doses because it's the upper and the lower the strengths of the total doses that the DECRO guidelines recommend. How the bias of the study was only for the patients. We need that they have the same number of the fractions. So because sometimes our patients can talk in the waiting room, so we need to have the same type of the schedule with the in terms of fractions.
Okay, thank you. The next question is also around the surgery and whether patients are receiving surgery. Were you tracking in your trial, were you tracking the number of patients that received any kind of further surgical procedure?
Exactly, no, we don't have we know the number of the surgery, but it's not an objective of the treatment, but it's possible. I think that it's possible to see with if we talk with our statistic specialist to see that. But in this moment, we don't know who is the which is these patients or the follow-up of this patient in concretely.
Okay, thank you. Back to the previous question, you had talked a little bit about the dose, the prescribed dose. What location are you prescribing the dose? Is it to the skin or another location?
Yes, no, we usually we treat with LINAC, so we use the same quality of for that we use in malignant disorders. So we made the prescription in a volume with the help of the CT scan.
Okay, yeah, the next question was whether or not you had a preference for KV or MV for your treatments in the knee. Sounds like you're using a LINAC.
Well, I don't have experience with orthovoltage, so we have to or kilovoltage. So we have to use the usually we treat with 6 MV photons.
Okay. The next question is just a general question. I think it applies also to Dr. Ott's presentation. Can you speak about any randomized trials showing the effect of radiotherapy compared to sham treatment?
Well, if in the trial of Mintem, that is randomized and they compare with sham, perhaps the number of the patients was not very high because if I don't remember, but it was about 14 patients, perhaps. So the result was for me perhaps a little confused because the sham the good response with sham was very high, about 14% of the sham. With the sham, perhaps when they make if I don't remember, but they only treat with one phase, only 6 fractions, and if they don't if they didn't have a good response, they didn't repeat the treatment. So perhaps this is the difference between this trial with sham. I don't know what is the opinion of the rest of the panelists.
Okay, thank you. We can hold that till the end if we have time to address that question to the rest of the group. Just one final question before we move on to our next presenter. Have you had any issues receiving reimbursement for these treatments? For example, you know, perhaps this is characterized as an experimental treatment. Are you getting reimbursed as a non-experimental treatment?
Yes, no, we offer these treatments free for patients because we receive a budget from Electa, because people here in Spain and our colleagues from traumatology, rehabilitation, and rheumatology, it's very difficult that they send us patients. So we have to make a marketing free program. We contact with several rheumatologists and traumatologists. And finally, we got to this number, to this high number of patients for the treatment.
Okay,
But
thank you.
in general, in general, it's sometimes it's very difficult that a patient here in Spain pay this treatment in the private way.
Sure, sure. Okay, thank you for the background. And I will turn it over to Dr. Rivas. Thank you so much.